But really, again, just wanted to walk through why melanoma clinical trials are important. What are the elements that you need to think about and you need to know about them, and kind of go from there. And I hope that I'll be able to answer any of your questions. Again, I'll be giving a bit of a high-level overview and happy to dive deeper on anything you guys would be more interested in hearing about. So I'm trying to advance here. Let's see. Okay. So, when I started treating melanoma back in 2005, it was a pretty tough time for our patients with melanoma. It had actually been almost 30 years. And one of my mentors, Dr. Kirkwood, had actually summarized data from almost 42 clinical trials with 7,000 patients that have actually shown that we couldn't really move the needle. We couldn't make people live longer. And we had a 5-year overall survival of less than 5%. And high-dose IL-2 was actually the only treatment that we had available at our disposal. And I just wanted to share this with you. Just we're medical oncologists. We love survival curves. And I'm just going to walk you for a minute through what a survival curve is about so that you would understand not just hopefully what I'm going to show you, but also for the future. So what you're looking at is a survival curve, and what you see on the x-axis here is the time. So it starts at time 0, and you follow patients along, and you see how this is counted in months in this case. And what you see at the top of the y-axis here is, when you say 1.0, it means 100% of patients. So you start following 100% of the patients at time 0, and you continue following them and see what happens with them as you treat them. And unfortunately, every time a patient dies, that curve decreases. So when you look at 12 months or so, you would say there's 80% survival. And this is what treating patients with high-dose IL-2 looked like, which is on the first part of the curve where a lot of patients are unfortunately falling off means that there's a lot of patients dying. But what you see on this part was actually probably what has sparked the most excitement and interest that has resulted in what we have in our hands today, which is the fact that the small proportion of patients that actually make it to 3 years or so, you would see this curve flatten out. No changes, no decreases. And what that means is that all of those patients are now survivors. And as you heard from Michelle, the survivorship is very important. We'll talk about how that proportion is increasing. But high-dose IL-2 was the only thing that we could actually hang our hat on because it was something that actually was capable of curing patients and allowing them to live almost 10 years and longer without cancer, which is quite amazing. The problem that we face with IL-2, and I personally treated a lot of patients with it, is the fact that it was really, really terrible. It was rough. It was really hard. Patients have to be treated almost in an ICU-like setting. And we had to select almost the proverbial marathon runner to be able to sustain the treatment. So it was really difficult. And the proportion of patients that we could really cure was really small. So that's where the 5% at 5 years overall survival came from. And then this happened. And I just wanted to share, again, there's a lot of survival curves. So wanted to show you this. This, for me, is an absolutely iconic image for melanoma. I was sitting in the room at the plenary session at ASCO in 2010, where this was shown for the first time. And what you see here is you see that survival curve, you see the drops again, but you see two curves that are actually not on top of each other. What that really means is that we compared in this particular style, it was comparing treatment with Ipilimumab versus treatment with a vaccine. And when these curves separate, it means that patients on one arm are surviving longer than patients on the other arm, which is something that we had not seen in the history of melanoma, patients with metastatic disease surviving because of a treatment that we gave. And that was an amazing development for us. Ipilimumab actually now cures about 20% of our patients, up from 5% with interleukin-2. And then again, since then, we've been so lucky in melanoma that drug development has accelerated. We have targeted therapy, we have immunotherapy. We have actually had 12 drug approvals in the last 11 years, including more recently encorafenib, binimetinib, and a triplet therapy that was just FDA approved of atezolizumab, vemurafenib, and cobimetinib. And what that really means is that our 5-year overall survival now is more than 50%, which is incredible, right? It's a 10-fold increase in the course of a 10-year period, which was amazing for us. And now I can sit in the room with a patient, and I'll show you this other survival curve. And I just did it last week. I had a patient come in with melanoma, brain metastases, first diagnosis. And I was bold enough to sit with them and say, look, we actually can cure about half of our patients with metastatic disease now, which is, again, incredible. And I wanted to highlight, this is actually 5-year data from treating patients with Ipi and Nivo, which is the combination that I think is the most effective that we have. And after 5 years, we now see this 52% on the right side that are alive at 5 years. Again, pretty much curing about half of our patients. So it's all fantastic. We owe it all to clinical trials, and I'll get into that in a minute. Now, having said that, this is all of the great news and how great this is for our patients. However, I really kind of want to highlight the stark reality. So you see, guys, all of these tables that we have here that talk about hazard ratios and these words that say improved survival. I am personally irritated at that space. I'll show you this slide. And if this actually is bothersome to you and looks ugly, I made it that way on purpose, because that black box, that box where we actually put all of our tables and our statistics when we give talks to patients, that space has actually been left open because about 50% of our patients died. They actually fell off the survival curve, and that's why the curve dropped, because they're not alive anymore and they're dying of melanoma. So we've done great, but we have so much more to do. And that's why doing clinical trials is so important, because it actually teaches us exactly what we should do with these patients. So what I'm going to share with you next is, as we treat these patients with Ipi-Nivo, for instance, and we follow them over time, especially on this study that had about 1,000 patients, what that allows us to do is to actually start understanding patterns of why are patients responding, why are they progressing, and here's what we now know about Ipi and Nivo. So you get about 57% of patients that respond to treatment, and then you have 45% that don't. And then you have patients that continue to respond, but even some of the patients that respond actually end up acquiring resistance. So a response is lasting in a vast majority, but in some patients it's not lasting anymore and they actually recur. So, and then, at the end of 5 years now, we know this is Ipi-Nivo alone, that 40% continue to show response. I mean, 50% are still alive, but some of those 10% difference actually progress and may go to other therapies. And so, as Jen mentioned, as Dr. McQuaid mentioned, our job is to actually try to figure out exactly what are the patterns, where do patients need more treatment, where do they need improvements in their therapy. And the other thing that's one of our goals is that Ipi-Nivo is really great and does a great job for some patients, but about 55% of patients actually have grade 3 or 4 toxicity because of it. So that is a lot of toxicity. So our job is to improve outcome, to bring more therapies, more new things to patients, but also try to get things that are actually less toxic and more gentle on patients, and can allow us to treat not just the marathon runner, but the 94-year-old that could still come up with melanoma. So really important. And then the fact that we treat patients on clinical trials also allows us, again, to follow them over time and understand patterns of what makes some of them respond and what doesn't. And here's targeted therapy, for instance. This is also a 3-year data from one of the large trials with melanoma. And what it actually taught us, so you see this elevated LDH, we actually found that a subgroup of patients really don't do well with this. They progress about, only 13% of them don't progress at 3 years, and their survival is only 25%. But then if you look at patients that have a normal LDH, and that's a simple test that is done, in your clinical, and with your kind of CBC and chemistries, and if they have less than 3 sites of disease, 62% of them are alive at 3 years. So even just targeted therapy is capable of helping that population. Because we have those patients on study and we prospectively from day 0 actually know all of these elements about them, then we can actually understand that data and understand which patients we should consider this treatment for versus that treatment. And then this is, again, more phase 3 trial. This is the trilogy trial, or the triplet that was just approved, Atezo, Vem, and COMBI. And this is actually a study that was placebo-controlled. So I wanted to share this with you because I want you to not be afraid of placebo. Placebo control is actually when you're treating a patient with 3 drugs, only one of them is placebo and the other 2 are effective. That doesn't mean that you're not treating them at all. You're actually treating them with what is the standard of care. And in this case, the interesting part of these 2 curves is that at 6 months, they looked exactly the same. So, you know, as a physician treating a patient, you would not know, not just because of the placebo, you would not know what's going to happen. And then as those patients are followed, at 9 months, it looked the same, but then at 12 months, it started separating. And now we know that this is actually a statistically significant difference, and that's why this combination was approved. What we also learned from following them on trial and being able to measure the response and prospectively do this is that the major difference is not the response rate, about the same patient's percentage response in both, but it was actually how long they responded. Again, information that would not have been gained in any way without being able to prospectively follow those patients. And phase 3 trials also fail, so they tell us when it's a bad idea to do something. So here's COMBI and Atezo, which is a combination, versus single agent Pembro, and actually it almost looked like Pembro may be better. So again, just reminding you of this big black box. We have a lot of work to do, but the good news is we have a lot of agents. So actually immunotherapy now, as well as targeted therapy, we have over 2,000 agents in development. There are a lot of clinical trials. So this is actually summarizing almost 1,000 of them. And as you see, here's a lot of them in melanoma. We're lucky in melanoma that we've been leading immunotherapy drug development. So almost every new drugs that come to immunotherapy is something that's being considered for patients with melanoma. So we have the opportunity to work with that. And just kind of very briefly, and again, I can go deeper on what's the difference between phase 1, 2, and 3 trials. I will tell you that, as you see down here, it can take 10 years to get a drug to be approved. It takes a lot of work. By the time a drug comes to phase 1, it's already been through a lot of testing already. So despite the fact that it may be the first time it's being used in humans, I have to tell you, one of the phase 1 trials we ran in melanoma, which is the one for Keytruda or pembrolizumab, was probably the one we learned the most from. It had 600 patients eventually on it, and it actually taught us not just what the right dose is, but actually who to treat. It taught us what happens to patients that get a complete response and you stop therapy. It's been an impactful study, despite the fact that it's a phase 1. So again, there's no need to be concerned or say that if it's a phase 1, then it's definitely kind of not helpful. In fact, some of the most promising stuff we have is in phase 1. Obviously, phase 2 is when we actually have efficacy, toxicity data. We know exactly what dose we should use, and now we're asking the question, how well does it actually work in terms of shrinking disease and controlling it? And then phase 3 is when something is really promising in phase 2. You're like, well, maybe this actually should be the new standard of care. So you compare it to the standard of care in a phase 3 trial. So with all of that, I'm just going to conclude with telling you that clinical trials are incredibly important for us to continue moving the needle, to cure more patients, to cure them more safely if we can. And, you know, what we do at MD Anderson, I can tell you, we have now 24 trials open. We have 27 before COVID, and we got down to 24. But really, just as Jen mentioned, we really think about where's the standard of care. And my simple kind of litmus test, sniff test is my trial better than the standard of care? Does it have the potential of being better than the standard of care? And that's the only time I'll do it. If it doesn't, then we should treat you with what's standard. And that's the decision we do make as medical oncologists. And as Dr. McQuaid said, we have the opportunity of having 10 oncologists here that do this, and we discuss cases among all of us as well. So when you come to be treated, we actually have the input of 10 experts in the field in terms of which trial would be most appropriate for you. So with that, I'm going to stop, and I'm happy to take any questions either now or maybe after Dr. Wong speaks. Thank you so much for the invite.